Hi, everybody. This is Dr. Aubrey, and this is part two, endocrine part two. So this is our third of the series, and endocrine pharmacology part two for the NPLEX review. So last week we did cover the diabetes section in detail. We're going to cover a little bit of review on that section, and then we're going to be moving through insulin interactions today, as well as thyroid, adrenal, sex hormones, and pituitary drugs. So today, our insulin contraindications, I didn't get covered very well last week, so I want to make sure that that is clear today and understanding the mechanism, risks, and exam patterns a little bit more by the end. And then we want to, of course, be able to apply this clinically when we need to. Okay, so let's overview those diabetes drugs one more time. We want to look at insulin agents versus non-insulin agents. So obviously we're using insulin when there is insulin insufficiency. So most commonly in diabetes 1, but now of course we know that DM2 also contributes to use of insulin at some point. Then we have to look at the hypoglycemia risk of the different medications, and we want to look at which ones actually do help with weight loss and which ones don't help with weight loss. And then, of course, we have some that do go through the kidney, so we want to look at the considerations there on whether or not they're affecting kidney function. So let's look at the combos here. So our main hypoglycemia risk is obviously if we're pushing the insulin production out of the pancreas, you're going to see an increased risk there. And versus just upregulating the amount of glucagon or the different mechanisms. So not all the drugs have the same way when you add insulin either. So obviously, we want to make sure we don't have too much insulin on board. That is very dangerous and can cause the hypoglycemia risk to be pretty severe. The pumps obviously are doing a little bit more time in real time adjustment to the insulin levels, but understanding the different types of insulin, we have, Lispro being fast, regular being kind of steady, and then the long term being the glargine form goes over time and doesn't wave. So the big one, probably contraindication. We don't like the sulfonylureas with the insulin pumps because they do push. So our main one we talked about was the glyburide, and it is an increases insulin release from the pancreas. It also has a very long half-life. So this is not to be combined with insulin very often, and especially not if it is in the elderly. This has a very strong risk also of chronic kidney disease. And so watch out for that. So elderly with sulfonylureas, we do not want to use the combo of insulin and sulfonylureas. Insulin and metformin is all the time used. So it is a safe combination. Oftentimes they're starting them on metformin, as you know, and then that if they don't change the diet leads them directly to diabetes. So full on, and so then they'll add the insulin in. You can use these together, safe and common combination. It does improve insulin sensitivity at the cell level, and it may reduce the dose of the insulin from the pump if you're using metformin conjunct with the insulin. So they like to keep it on board. This one, the insulin and the pioglitazones, see if I can pronounce that, pioglitazones, with the TZDs. These guys, you want to be very careful with because these guys are going through the kidney. It's very important to not use this combination at all if there's a higher risk of heart failure. So in the elderly in particular, and with heart failure symptoms, the insulin and the pioglitazone need to not be used in conjunction. And then, of course, the GLP-1s. So we talked about these last week, but they're primarily being used to add weight loss benefit. And they do, they're going to have a synergistic effect, obviously, with the insulin, but there is not a contraindication here. And it does look to me like they'll probably start metformin, then they may do this before the insulin, I hope, and try to bump it up. And then, of course, we know everybody needs for the weight loss benefit they have right now. So maybe still needs to be closely monitored what we're doing with the insulin level when these guys are there, because they do increase lower blood sugar, and you can have, the combination can be cause some hypoglycemia. It doesn't look like it's that one does not look like a high risk of it though, so it seems to manage well. Okay, SGLT2s. This is the canagliflozin. Canagliflozin. There we go. Canagliflozin. This is the one that actually makes us lose sugar out off of the kidney. So this one, it increases urinary glucose loss. Combination is allowed to use this one with insulin. It does have a risk of euglycemic DKA, which is where the blood sugars look normal, but they're in ketoacidosis. So that is important to pay attention to, because you won't be able to catch, we're not catching it, the ketones are going out. So you do not want to be using this drug if there is a surgery going on, or if there's illness going on. And these do increase the risk, I think we talked about last week, of almost all genital infection. So you want to be careful if there's anything like that happening. Urinary and genital infections. Okay, so your red flags for your meds here are elderly and the gliperides, the congestive heart failure and the pioglitazone. And then I forgot to talk about that again, but the GLP-1s they need to be contraindicated if there's any risk of thyroid carcinoma. And so men-2 in particular would increase that risk. So we need to make sure those aren't being used. And then kidney disease plus metformin. So metformin and kidney disease will for sure be on the NPLEX, I'm guessing. And then the SGL2s and any infection need to be considered and avoided. So that's the combo things to look for with the insulins. And then that's, like I said last week, if you want to review those, they're on the diabetes meds are on the previous video. This week, so we're starting into the thyroid meds here. And we have a couple of thyroid medications that are covered on the board. Levothyroxine and liothyronine, obviously. So I think all of you guys know this one easily and hopefully. So levothyroxine is T4. It has a long half-life. It is first line with hypothyroidism. It did not look to me like they put desiccated or Armour on the list that I saw, but right now it looks like just the T4 and T3 are on the list. So just remembering levo and liothyronine is rapid onset, short half-life. Those two seem to be the most important to look at. Let's see if there's any other tips they have for those. So the half-life of levothyroxine is 7 days. Its absorption decreases. Oh, of course, we can take it with if you have iron, calcium, soy, or PPIs. So it has to be taken on an empty stomach in the early morning. And we're still using it for Hashimoto's and hypothyroid version of that. The adverse effects with levo are tachycardia, anxiety, and weight loss are the main ones. So obviously, if you go too high, it's going to start looking hyper. And you want to start lower dose in elderly and with cardiac disease. Liothyronine is an active thyroid hormone. It has a short half-life, so it's 1 day half-life. Usually, seems to me like my patients run out after about 12 hours, but we'll say 24. Quick onset, not preferred long term. So it's only there, obviously we need to be testing and see if it's needed. Um, this is indicated for severe hypothyroidism, mixed edema crisis, and then the adverse effects, as I'm sure all of you know, are arrhythmias and anxiety. They did not put iodine onto any of the information here, so it looks like this test is just covering real basics on the thyroid. Uh, okay, then we have the other side. So we have the make sure I pronounce this right, methimazole. And methimazole is the first line for hyperthyroidism. It's a once daily dosing, and it does have an adverse risk of agranulocytosis, so we need to be careful with that, obviously. Um, if the patient develops a fever and a sore throat, this needs to be stopped immediately because we're going the wrong way. And then we have PTU, which is propithiouracil is preferred in a thyroid storm. And early pregnancy, it is being used here. So they'll use the propithiouracil in first trimester pregnancy if they're feeling like there's a thyroid storm risk. It does have a higher risk of hepatotoxicity, so it's you need to be careful with it because it blocks. It does also block T4 to T3 conversion. So these are our two hyperthyroid approaches. The PTU does have a short half-life, so you have to have multiple daily doses. It also it has a risk of agranulocytosis as well as the hepatotoxicity. So, but the big thing on the test probably for this one is that what if you have a pregnant patient that's looking like she has hyperthyroidism, it's probably going to be the PTU. All right, and then desiccated thyroid, just in case, it is on there, obviously, is a mix of T3, T4, and it does have variable absorption is the main issue with it. It is an alternative to the T4, and it's not preferred by the NPLEX. So the NPLEX, if you see that desiccated on there, you want to make sure that you're picking not desiccated because of consistent dosing. Okay, so here are the adrenal drugs, and primarily steroids and mineral corticoids. And we don't cover epinephrine on, I'm not covering epinephrine on this section because he really, it seems like it's listed under the neuro section. So I'll cover epi a little bit more in the other section. So the list on the NPLEX for this one has the corticosteroids, there's one mineral corticoid really, and then that is it. It did seem like there was a very long list of corticosteroids, about 8 of them or something. So the main thing to look at is the categories, what they do, and how they're working. Eat what they do in that category probably is the best way for getting through the exam. But the big ones that we wanted to talk about, prednisone, dexamethasone, and are probably the big two. And then the mineral and fludrocortisone is the mineral corticoid. So that is the one that is the only one that is salt. So here are systemic glucocorticoids. The hydrocortisone is short acting. It is a gluco and mineral corticoid both, but primarily we use it for that. It does have, it is being used for adrenal insufficiency and allergic reactions and inflammation, of course. And it can cause hypoglycemia and immunosuppression, obviously, since we're using it for that. So that's the hydrocortisone. Prednisone is the anti-inflammatory glucocorticoid. It is an intermediate acting level, and the prednisone is a prodrug. It is converted to prednisolone in the liver, and so we need to, I guess, it goes in and converts to prednisolone in the liver in order to activate. This is used for autoimmune, primarily for asthma and rheumatic disorders. chronic inflammation. It is contraindicated in osteoporosis, and you do see, or it actually can contribute to osteoporosis. Excuse me, that's an adverse effect. It causes mood changes, weight gain. They didn't say weight gain, but hyperglycemia, leading to weight gain in my experience, and increased infection risk, obviously. And with the prednisone, you obviously have to taper it off if it's being used long term. And then we have methylprednisone there, which is IV or oral. That is being used for acute flares of asthma or MS, and only usually, intermediate acting, but it's pretty acute only. So those were the big three that the review lady talked about. Dexamethasone, the long-acting and high-potency ones were dexamethasone and betamethasone. So they are long-acting, very potent, and dexamethasone does not have any mineralocorticoid effect on it, which might be beneficial. The half-life is 36 to 54 hours on that one, and they use that one for cerebral edema or severe asthma reaction, and they sometimes do a suppression test with that one. So they have a dexamethasone suppression test to see the reaction. And then fludrocortisone is the only mineral corticoid. So let's move that to the next screen. The fludrocortisone is a strong mineral corticoid. It is for Addison's primarily, and it does cause, or it's used to treat sodium and water retention. That it seems like this is probably the one they'll bring through on the NPLEX because it's the only mineral corticoid. All right, sex hormones and fertility. I mean, and I think probably as this is going to be ridiculous for you, love, since these are very basic compared to what you're already doing. But this is the NPLEX version of the sex hormones. So we have estradiol, estriol, and progesterone on the list. They did mention pregnenolone, we'll talk about as a little bit, quite a bit on the review, but it isn't listed on the drug list. So estradiol, according to on-label use, is for estrogen hormone and is a hormone replacement therapy for menopausal symptoms. And the main thing for this is that it is a thromboembolism risk is the main adverse effect. There is some breast tenderness with it, and it is contraindicated with smokers over the age of 35 and with anyone with a history of clots. So again, estradiol's primary is HRT. Estriol is less potent, that's all they said about this, less potent estrogen used for vulvovaginal atrophy and minimal systemic activity was all they said about estriol. It seemed like when that has a lot more use in lowering inflammation in the research I've done, but for this purposes, it's used topically on the vagina. Progesterone is HRT balance again, endometrial protection. This does have a sedating effect because of the GABA receptors in the CNS being activated. It does balance the estrogen out. It is to prevent endometrial hyperplasia specifically, and the adverse effects are sedation and mood swings. Sure, they don't have breast tenderness on that one, but that's funny. Um, and then on this exam, it really looks like we want to kind of understand the oral contraceptives, and in particular, this levonorgestrel seems to be like it's going to come up. So that's your emergency contraceptive, progesterone, or it is used in the IUD hormone also that's used in Mirena and those things in a time-sensitive way. So that one can be levonorgestrel in a very low dose. Progestin is, used in the IUDs or in a higher, like I think it was 0.5 to 50 is used as the day after pill. So that's most likely to be on there. Northen, nor Norethindrone is the progestin-only pill, which is safe in breastfeeding and it has a lower clot risk. So those two might be the biggies that we look at. Here are the other ones we're using for oral contraceptives. Ethyl estradiol represent the estrogen-containing contraceptions are the ethinyl estradiols and sometimes added to the progestins used to test on the NPLEX. This is the test for clot risk and estrogen exposure. So they'll bring that up a little bit more probably in that context. Drospirenone is an anti-mineral corticoid with a hyperkalemia risk, and it acts a little bit like spironolactone. So that one can be mixed with ethinyl estradiol in the birth control pills, and probably is being used more than for people with like PCOS type symptoms. And then the Depo-Provera shot obviously is um, therefore, it's an anti-mineral corticoid, also like spironolactone. It does have a risk of hyperkalemia. It does have a clot risk. It is longer acting, injectable, and it is adverse effects of bone density loss and weight gain with that one. So I'm not sure how much they're going to cover these on the exam. It does look like those were the names of the ones that came up, but the biggest thing it seems like with the estrogens, as far as knowing risk factors, is the clot risk, and then that the progestin has a much lower clot risk than the estrogens. Okay, fertility. So we have HCG and clomiphene. Um, The HCG is not off-label use here at all. We're only talking about the Western medical use, and basically used to mimic luteinizing hormone and trigger ovulation. This they're using in actually females and males, it said, to increase either ovulation or sperm production. And the adverse effect is ovarian overstimulation syndrome. The clomiphene is a SERM, and so it increases both FSH and LH ratio, or increases the ratio of FSH to LH. So let me see is it an active? It's increasing, it's blocking the estrogen receptors just in the hypothalamus. So it's making the body think it needs to make more and then increases ovulation. So obviously your risk with that one is hot flashes because your hypothalamus is going that way. And it can create multiple gestation if used for infertility, not for contraception, is the comment they have on that one. All right, so those were the female sex hormones, and these are the androgens. The testosterone and DHEA are the only two major androgens on the list. So obviously testosterone is the key hormone for hypogonadism, um, male sexual development, and then the DHEA is for, they have an active form of influencing hair growth, but obviously it's a precursor to androgens and can be used over the counter more than the testosterone. So it can be converted directly to testosterone and increase the testosterone production. Both are going to, an increase in overall testosterone level will improve the hair muscle growth and hair strength, all of the testosterone things. Testosterone is contraindicated if there's prostate cancer, obviously. And the adverse effect is polycythemia. So we want to be careful with too much. Uh, Acne, edema, and liver dysfunction also can happen with testosterone. The primary indications were the hypogonadism, and I forgot to say gender affirming therapy. So if we're doing gender affirming therapy, that's going to move on. So our androgens. So uses, there it is again, hypogonadism, gender-affirming therapy, adverse effects, polycythemia, acne, edema, liver dysfunction, contra in prostate cancer. DHEA is the weak precursor supposedly for possible and can be used for possible libido support. And then she did bring up pregnenolone here, the review lady. She, because it is a direct precursor to everything, the androgens and the cortisol, and so the mineralocorticoids and the glucocorticoids is what it sounded like. It's a precursor to almost all of it. So it can be used here as a neurosteroid precursor also for fatigue and mood. It isn't used as much because we can't determine where it's going to go. So it may go to cortisol or it may go to the androgens. She said it was not much relevant on the NPLEX may not be covering that as much. All right, what else do we have here? So DHEA, DEA license, obviously, to prescribe testosterone. And there was not even a conversation on the review about, the inability to produce it in the future or anything else like that. So I'm sticking with the basics on it. Bone meds, our favorite. So here are the bone medications that they have on the coverage. See if I can pronounce them. Alendronate must be taken upright for 30 minutes prior to sleep because it can apparently eat through your esophagus and cause esophageal varices. In addition to the jaw necrosis from the bisphosphonates. So that is, it does look like that may be first line. The alendronate, the bisphosphonate, is being used to inhibit the osteoclast. Seems like a great idea, but it looked like when she went through the review on this, that it actually contributes to long-term remodeling difficulty. And so when fractures occur, they shatter instead of, it does seem to prevent short-term fracture, but long-term, the bone remodeling has not been done correctly. And so the bones will actually just shatter and be very difficult to replace. So, bisphosphonate also showed better. It was correlated, oddly, it was correlated with increased vitamin D3 and calcium intake on the testing. So make sure that it bring in those two if you're going to be using it. Denosumab is a rankle inhibitor. So that one is an the denosumab is SQ every 6, so that one's longer term. It does have a hypoglycemia risk, and it is contraindicated or it increases hypercalcemia infections and dermatitis. See if I can find my info on that one. Um, it's that one also seemed like it had something to do with correcting the calcium and vitamin D before starting it was the difference of whether that one actually worked as well. So that one inhibits the breakdown. Then we have the raloxifene is a SERM, and this one to me clinically actually seemed like kind of a good idea. It has an estrogen agonist on bone, but an antagonist on breast and uterus. So that was interesting to bring, the calcium primarily into the bone. It's used for osteoporosis in postmenopausal women and to lower breast cancer risk. But when she talked about it in clinical practice, it has a higher risk of DVTs and pulmonary embolisms and hot flashes. So it does, I'm not sure how much this one's being used clinically, even though it seems like it might be the best idea. It did have that pulmonary embolism thing that we don't like so much. And then calcitonin is actually being utilized as a drug. So they will put it, they'll just use a calcitonin drug. So to inhibit the osteoclast and used for hypercalcemia and mild osteoporosis. So obviously I would prefer calcitonin to all of those. I'm not sure what the long-term effect is on the thyroid if you're throwing calcitonin in all the time. But those were the main bone medications that are on the market and we're using that according to the NPLEX review. Okay. And lastly, we have the pituitary ones and neuroendocrine. So we had three primary pituitary drugs here. Desmopressin, which is synthetic vasopressin or a synthetic ADH. This is to treat central diabetes insipidus. So I don't know. I have never seen a DI patient. I don't know if you have, but it has a risk of hyponatremia, obviously, because you're going to be dropping your, well, you should be retaining water, so losing your sodium. Um, Not sure what that doesn't make sense. ADH holds water. Treats central DI. So we're keeping the water in the system. I would guess the main thing would be uh, increase in, this says it's nocturnal enuresis is the treatment uh, indication that we're using it for also. So central DI with nocturnal enuresis and hyponatremia or not enough sodium is the adverse effect. I'd really wonder what happens when we give people that. Somatropin. Uh, so let me make sure I pronounce that right. Yeah, I think that's right. Somatropin. The mechanism of that one is that it's a growth hormone analog. We do give this one for growth failure in children, so they're giving somatropin to increase growth when there's not development happening. The adverse effects there are edema and hyperglycemia. And the octreotide is the opposite. So we have somatostatin analog, which is being used to treat acromegaly. So we're going the other way there, or carcinoid syndrome, or variceal bleeding. I'm not sure I understood why that one was, but that is the three indications of those. This one can cause gallstones and GI upset. So those are the adverse effects with octreotide. A kind of strange one, so they'll probably be on the test. And bromocriptin and leuprolide are the other two. So bromocriptin is a dopamine agonist, and it's being used primarily for hyperprolactinemia or Parkinson's. And the um, adverse effects here are hypertension, orthostatic hypertension, or POTS probably, and nausea. So bromocriptin, um, I believe what else did she say in that one? That's it. We're trying to help treat any sort of prolactinemia. And the leuprolide is a pulsatile for endometriosis, prostate cancer, and precocious puberty. So we're trying to pulse the pituitary, pump it was kind of what I was feeling. Pulsatile for stimulating luteinizing hormone and FSH. If you are trying to prime the pump, essentially, or they can use it continuously to suppress it if if they're starting puberty too early and they want to slow it down. So the leuprolide is uh, directly acting on the sex hormone production. Um, it does cause hot flashes and potentially bone loss if you're messing with the estrogens too much. All right, so our adrenal medication effects, the big side effects to look for on the test would be Cushing. So if we've increased cortisol too much, mood changes with particularly with the prednisones, cortisol fluctuations altering mental health, and skin changes. So looking for those three things as flags with your prednisone and prednisolone, all those. Dexamethasone, probably not. And then the adverse effects of the sex hormone medications, the main thing we're looking for is the blood clots and especially the risk with smoking and clots risk. They're looking at is the exposure systemic or local is one to look at with this too. So if they're probably going to throw a DVT or pulmonary embolism potentially onto the test. And then the local effects would be more like headache, nausea, breast tenderness, fluid retention. Um, What else did they say there? Weight gain, migraine with aura, estriol has a lower systemic risk. What else? Bone density loss, hyperkalemia with the mineral corticoids, anti-mineral corticoids, acne, mood changes, and then at the extreme, ovarian uh, enlargement, all the fertility stuff. Not sure what they're going to ask on those. I think it's going to be blood clots. All right. And then with the bone meds, we're looking at osteoporosis risk, calcium deficiency, and medical interactions being the main questions. So increased bone fragility or fracturing from splintering, and then of course the jaw fragility with those meds, and then the calcium not being high in the diet exacerbating the problems with these medications, and then in contraindications with um, medication interactions. Where were my drugs that were contraindicated? Antacids obviously are going to be lowering your calcium intake. So they may be asking about patients with GERD or patients that are on PPIs and to have dysphagia or that sort of thing. They need to avoid the bisphosphonates because of the esophageal risk. Definitely need to be seated or upright for at least a half an hour when taking that one. And the increased absorption of, let's see, iron also. So it looks like there's a severe renal impairment possible with that bisphosphonate also. Ooh, didn't read that one. Hypocalcemia obviously has to be corrected in all of them. Avoid, uh, my guess is on the test, they'll also bring up not having enough vitamin D or calcium before bringing in the agonists. Our raloxifene has, again, higher risk if they have a history of a DVT or pulmonary embolism, higher risk if they have any sort of clot risk, and they need to not be utilized with other estrogenic agents, obviously, since we're being really specific about targeting with that one. Calcium binds medications, so it needs to be kept away in time from these medications. And you want to be careful with the bone meds and the thiazide diuretics, or you can increase your hypokalemia risk because they are calcium sparing, and not to be used at all with sarcoidosis or granuloma disease. Adverse effects of the pituitary ones kind of seem obvious. You can, if you're going too high or too low. So the main one they talked about was the acromegaly-like symptoms. So be patients may experience noticeable facial and limb changes. So you're going to see changes in fluid, glucose, gallbladder, or bones is where things have been disrupted with the pituitary. So if the bones are getting too weirdly shaped or too long, if the glucose levels are dropping from the ACTH, or if there's stuff showing up with mineral, the mineral balance with the vasopressin. They did say gallbladder here too, which I'm not completely I understand, but I think that's that side effect, the GI and side effect from one of the meds. All right, we made it through. So these were the second half of the endocrine or meds, and next week I'm going to be doing GI, hepatic, and derm because there aren't very many meds for those three. So I will stop our recording.